maybe in the same order, I'll start with the CML and ask Dr. Amaro and Dr. Haddad for comments. So with the data with the asciminib, right, that has emerged, and you highlighted, Fadi, where do you see asciminib now being used in routine practice outside of trials? Is it frontline in your opinion? Would you use it second line? What are your thoughts? And then same for Dr. Amaro. Maybe you can start, Fadi.
Yeah, so I think asciminib, definitely in the second, third line, I think the indication is very strong. It's the only one that is at least FDA approved in the second line, like after second generation TKIs, if you want to say that. Third line, it's been shown that it's very effective. It's safe if you want to compare it to ponatinib, for example. But in the first line, I think the indication is definitely there, but maybe here we have more choices in the front line. How I would place asciminib, I think I would tailor it to two things. Number one, to I would say the aim of therapy. Mm-hmm. I would say maybe younger patients or patients who just want to take treatment for like 5 years or so, stop. I would favor to go for a more potent drug rather than imatinib, because we still do see a lot of imatinib in our practice, patients referred to us. So maybe I would go with asciminib, or I'd go with second generation TKIs rather than maybe an older patient or maybe patient with toxicities, where I would use maybe imatinib in that case is justified. And number two, the patient comorbidities, definitely. I think asciminib is overall a safe drug to be used in the frontline setting. But I think we do have all three second generation TKIs that are as equally approved. I think they are as equally effective, all of them leading to good survival. None of those drugs in the frontline setting have shown improvement in treatment-free remission, although asciminib did show that it's resulting in higher major molecular response, deep molecular response compared to the other second generation TKIs. But I think we do need longer term to see if this will translate into potentially more patient being completely cured and stopping therapy without relapsing. And I think probably Dr. Moro could comment more on that.
Your thoughts?
Maybe I'll be a little bit avant-garde then.
Sure.
I think you have to synthesize this data. Let's look at the efficacy first off. This was a very good trial, this randomized trial, because it was physician's choice. So, we did what we were going to do when we wind up treating older and higher risk patients with imatinib. But when you have a trial that shows both safety and efficacy, that's a very hard argument why you shouldn't be using that as your first drug. I think the two main arguments people are using are cost and safety. Mm-hmm. It's a little bit less well publicized, but asciminib's been under investigation for 14 years.
Wow.
The phase 1 study was 350 plus patients, studied some of them for up to 10 years. We presented and will publish finally 8-year safety data. So while it's good to argue about long-term safety data, we actually have long-term data. And patients treated at ranges from 20 to 200 milligrams twice daily from phase 1. I have some of those patients. That's all, so it's a little hard. When they're in your clinics, you know the safety. But I think the bar is very high when it comes to a new drug. But we have a good look at safety. And now we have randomized data. And we do have 2 years of data. And I think most of the adverse events do surface by 2 years. So if you look at the details of the safety, I think there is a bit less myelosuppression, which tends to interfere with treatment dose intensity and exposure. There is some discovery in there. For example, lipase elevation, which is a bit of a nuisance toxicity, generally doesn't lead to morbidity and mortality. But we see with all TKIs, it's not a nilotinib, ponatinib, and asciminib problem. I think the most important toxicity is cardiovascular. And I think with a level playing field, we are seeing low rates, maybe similar to the second generation drugs. And we're getting more skilled at identifying and adjudicating those adverse events. So we still want to answer that final question. But in the end, if you have a more effective and a safer drug, my preference in frontline would be asciminib. The other thing to synthesize a bit is the resistance data. So, it was a beautiful, you gave us both pieces of the data, that there is nice studies from Australia looking at other myeloid mutations and how that plays into resistance. So with asciminib, the number of resistant patients is clearly less. In that frontline study, it was about half of patients needed to discontinue therapy, and half of them for adverse events, and half of them for clinical resistance. So it's a small problem, but it's a problem we can be smarter about. The mutations, yes, are myristoyl pocket mutations. If you look at the treatments they got, many of those patients are treated with dasatinib. So we can easily salvage those patients with a low-cost, studied and familiar second-generation inhibitor. One step further, we could probably be smart about looking at our CML patients in general. I think my colleague mentioned that. Sequence patients, and the patients with other myeloid mutations generate more Abl kinase domain mutations. So we can sort of set us up for knowledge and really being able to sort those patients a lot better. Honestly, patients without kinase domain mutations and clinical resistance to CML are a much bigger problem. Historically, patients with mutations actually do better in salvage settings than patients without mutations because the mechanism of resistance isn't known. So, long-winded argument, but I think because of it, it's a high-quality study and this long-term phase 1 data, I think asciminib it has a good resume, for us in the front line. We still have questions to answer, and no, I certainly wouldn't argue with anyone that would say that imatinib is not a good drug in certain settings. Of course, what a good problem we have that the first drug we developed 25 years anniversary this year still is effective, safe, and broadly available, especially outside of some of the more economically advantaged countries. And second-generation inhibitors, many are available generic. That's a huge advantage. So time is needed.
But you did mention one thing, and if you could elucidate more on that, is cost, right? What are the differences in cost? And I know in the US, this may be coming. Historically, it's not something we've worried about. But ex-US, I work a lot with India and other countries, Lebanon, that is a huge aspect. So how do you see us factoring that? Is it something we can factor, we should not factor? What are your thoughts?
We could have a whole nother panel discussion about the economics of healthcare, right? I think it is definitely something that has to be part of our vernacular and our thinking about the drugs. The one thing to say would be that we don't know whether, for example, asciminib will put more patients into a cure.
TFR, right.
Well,
Which could be.
I think we could probably already say that it's going to avail more patients to a treatment-free remission opportunity.
Can I ask a quick question?
Oh,
I'm sorry, while we're on asciminib, just a quick question.
Yeah.
So the frontline trial, it was asciminib versus investigator choice, right?
Right.
For the frontline?
Yeah.
And there was an overall benefit. But I thought I remembered that when they did a sort of a subset analysis, the majority of the benefit that was seen was between asciminib and imatinib, and maybe the second-gen and asciminib were very similar. Is that true? Or
So maybe first, the cost, and then what Dr. Gadia is saying.
But so back to the cost. I mean, the one way to look at it might be that if you have more patients eligible for treatment-free remission, and that becomes more familiar and the path patients choose, you'll automatically have more patients that are cured because you're having more patients that are available to undergo TFR, even if the rate stays at 50-50. If the success rate increases, that's a game changer because now we have more patients eligible, more patients successful.
Right.
We do have some small trials, one in our CML consortium, in second treatment-free remission where we're adding asciminib later in the course, and I think we have a signal that there may be some ability to, asciminib may push patients into a cure stance because it's a much different inhibitor and maybe it does have better effects on MRD. I don't know if that's going to hold up with the larger numbers in the trial, but that could be a game changer.
Then you have the cost argument there, and then the data,
I'm
right?
glad
the
to-
subset.
yeah. So you're absolutely right that this study couldn't be designed to show asciminib was superior to each of the second-generation TKIs. The numbers would have needed to be very large. But the analysis at the first presentation, which was 1 year follow-up, there was marginal differences if you looked at asciminib versus the second-generation TKIs. But at the second year, now there were more statistical differences, even though it wasn't powered to show that asciminib was superior for MMR rates and deeper molecular response rates. It was immediately superior against imatinib, and it was immediately superior against all choices collectively. So while it wasn't powered and designed to say it, I think you can say now that it is probably superior to second-generation TKIs as a subgroup.
So on that, maybe another topic here is TFR, right? Now more than 10 years of discussion and publications on this, and basically my question to both of you, and we can start with Dr. Mauro here and take it to Dr. Haddad, who are you thinking about for TFR? What are your criteria for a new CML today? Okay, maybe Dr. Haddad, go ahead, Fadi.
Yes, so I think TFR should be offered actually to all patients. I think if I am a patient, I want to stop treatment. I don't want to remain on treatment forever. Of course, patients who are younger, we can potentially spare them toxicities long term. We can potentially spare them cost long term. So I would be more inclined to offer that to a newly diagnosed younger patient, but as well as older patients who are motivated, wanted to stop therapy. I think offering that to all patients should be done, as long as the patient fills some of the criteria that we all know, because we need to know that the patient, after stopping treatment, they are compliant to come for follow-ups, etc. Because we do see actually in patients, in clinic, few patients who do not want to stop, because those patients don't want to really get tested. Some people get anxious of me stopping treatment. What if the CML comes back? What if I'm gonna miss that? So there's this patient aspect, and there's also number two, how much the patients will respond to treatment, because we know that there are some patients who may go into a very good molecular remission, but do not go into a very deep and sustained long-term remission to be able to stop therapy. So in my practice, I would offer it to all patients who are compliant, who achieve the molecular milestones to stop the treatment.
And what are those, like for a frontline patient? Like how many years do you think?
I think different groups have investigated different criteria. I think, as I showed from the French group, they rely on MR 4.5 for 2 years plus to stop. Us at MD Anderson, we rely on MR 4.5 for 5 years plus to stop, because we showed that it resulted in higher success rates of TFR. Some other groups advocate for MR4 rates for maybe 2 to 3 years. So I think there are different groups, but what I would say is the longer I would keep the patient in a sustained deep remission, the better that is to get higher chances of actually stopping treatment and not relapsing in the future.
And Mike, maybe what about non-frontline patients, somebody who has had to switch? Is there any potential for TFR ever? And if so, how? Because I don't see so many, but I see patients, and this is a question they have, okay, they were on imatinib and something happened, we switched them. Now they've got 5 years dasatinib and they're CMR for a couple of years. What do you think? Yeah.
Yeah, I think we have some trials that show that. Probably one of the early ones was the DAS-free trial, I believe is the name, where second line and front line dasatinib patients, they were generally a mixture of intolerance and resistance, but there were no differences in TFR success, more nominal differences. I do believe a patient who converts to a very sensitive phenotype and has a very convincing deep molecular response in a later line of therapy is probably amenable to treatment for remission. I mean, it might be a little bit avant-garde to say a patient who had progression to advanced disease. I think that's troublesome, or high-level resistance. But, for example, we have patients parked on asciminib now for 8, 9 years in the phase 1 trial who have not had molecular positivity for 9 years. That's low-hanging fruit probably for discovering later line therapy in TFR. And I just want to add some color commentary to this TFR discussion. One of the most interesting questions we have is that how is it that we have people who are off treatment but yet have BCL-XL positivity?
Yes.
They are patients who look negative, and we all have different bars we set for deep remission and length of remission. There is definitely something to length of time on treatment and length of time in deep remission from all of the data, from the original French studies, from the Euroski trial, from your data. You've been really showing us more about longer-term treatment. But there's probably differentiation we can do to understand the signal we see. We may be seeing BCL-XL from B and T cells, which is not going to recapitulate myeloid disease and lead to CML relapse. So there's more technology needed to understand what we're looking at in a TFR-eligible patient if they are BCL-XL positive. So
that's very interesting. And then last, maybe, because actually you showed this nice data, Fadi, about, which we've all discussed many times at MD Anderson, that just having, and what you're going on as well, Mike, the BCR-ABL positive, even 3-4 years in, should not drive a knee-jerk change in TKI. I mean, we see this in the community all the time, though, right? At 18-month, 20-month, they are not achieving MR4 or whatever it may be.
The consult for transplant because the
yeah,
PCR is still
or
positive.
like, I went through 3 TKIs, and you're like, actually, none of them was really a failure, right? And they come to us for a trial of asciminib in the 4th line or whatever it may be. So I think the question here really is that, is there any number of BCR-ABL at some point that makes you nervous? Or you say, if the patient is young, healthy, and okay, they have 1.5% at 24 months, but they're doing really well, would you change this patient to something else? So what I'm trying to say is there a number where you feel like I must change it? Or is it really more based on the hematological parameters, the overall clinical scenario, or we monitor? What?
Wow,
Yeah.
that's a very
I have a couple of patients like this, and I've just continued monitoring because I'm like, what am I going to do?
Yeah,
You know?
that's actually a very good question. I think also the message should be like, we also need to stick to the milestones, right?
Right.
Like we have the guidelines, we have the LN recommendations, we have the milestone that we need to achieve. It's not, because some people sometimes would misinterpret the data saying, it's fine if I don't achieve the milestone. I think it's optimal that our patients do achieve the milestone, the CCYR at 1 year, etc. But let's suppose a patient like yours, 1.5% after 15 months of therapy, should I go ahead and change? What I would say, so first, it's reasonable to change, of course, because
Sure.
because this patient technically failed the 1 year mark. But I would say if this patient, I've been following the kinetics, this patient have been dropping nicely, maybe at 3 months, 6 months, have been dropping nicely. At 1 year, didn't hit the mark close, but the slope is going down. Personally, I would keep that patient on and reassess probably after 3 months, see if the PCR is going down. If it's going further, keep going. Because also I think the German group reported last year that even sometimes failing some of these milestones, but like as long as you are maybe close to the 1% mark, obviously we can go into this data in more details, but I think slow variations at some of these earlier time points may not result in detrimental over survival on the long term. So what I would say, if a patient is maybe more than 10% after maybe, I would say 24 months, like this is like maybe 1% after 24, more than 1% after 24 months, like this is 2 years of treatment, this patient did not achieve a cytogenetic remission. That's a case that I would definitely need to switch, if this maybe answers some of your question.
Well, I think, and maybe I'm wrong, but what I recall Dr. Kantarjan saying is the cytogenetic remission at 1 year is the only main point that has shown survival, OS
Correct.
advantage. So they do achieve that, a lot of them, but then they have this RT-PCR that goes on at 24, 30 months at some low level, 1%, 0.8%, 1.1%. Do we need to keep switching to achieve this, or maybe you switch once? I don't know. What do you think, Mike? How would you? I'm sure you have a lot of these patients like this.
Sure.
Yeah.
If you just looked at PCR and said, should I change the patient, that's probably not enough. You know, let's look at people who don't have a 10% reduction at 3 months. There's probably multiple groups there. There are people that probably have adherence and compliance issues. That's not a treatment failure. That's just a mechanics of treatment. There are probably people with other myeloid mutations that maybe have a resistance phenotype. But we just don't know it, because that's not part of our early testing. But if we did it, we might understand that. There are probably patients with true resistance who need to switch. So you know, it's heterogeneous. I think you guys you were just talking about some of the key. What has the data shown us over the years? Cytogenetic remission, probably major molecular remission, really does protect patients. CML inherently is a disease that's going to either try to proliferate or progress generally early if it's got the mechanics. That's why WHO changed the definition. You know, let's be smarter. Let's probably, you know, B lymphoblasts in the bone marrow or the peripheral blood are probably a very bad prognostic sign. It's not clear in the data that all those patients progress, but that's, you know, it's like P190 or other phenotypes, other myeloid mutations. So I think once that all clears, and if you have someone that has time on their side and they have relatively good disease control for a relative amount of time, you may have passed through the period of risk, and you may not necessarily gain a deep remission for TFR or a complete molecular remission or a deep molecular remission, and they may be okay. So that wasn't a good answer, you know, because it's sort of like saying it's very confusing.
It's a tough one. I mean,
But
exactly.
I think you have to look at the patient individually with regards to what's actually driving the missed milestone,
Right.
and then look at, well, what else could I know about the patient? Because there are a lot of cases where the disease can be quite indolent, and I think we know what some of the features are that make it not so.
Yeah, I think the compliance is, as you mentioned, a critical thing. And on the superficial view, often patients say they're compliant, and you start digging and asking more, and 60-70% of the time that may actually be the issue, right? So I think we'll move here to the MPN. We have time, so we don't have to worry about the clock here. We can take a few extra minutes or an hour, as Pankit was saying. But so you covered a lot of ground, Pankit, right? So maybe let me start frontline. So today, for a frontline patient with myelofibrosis, large spleen, presenting to you, is there any role for anything combination-wise, or is it just single agent JAK inhibitor, and how do you approach that? And we'll ask everybody their thoughts here. Yeah.
I'm assuming you're asking, of course, as standard of care in clinical
Standard of
practice
care, yes,
today.
outside of a
Right.
trial, outside of a trial, yeah.
Right. So if a person is symptomatic and/or has splenomegaly, coming in with intermediate or high-risk myelofibrosis, I would say just do a JAK inhibitor up front. Okay. Now that comes with a caveat. So let's agree that we should do a JAK inhibitor in that setting. The most commonly selected JAK inhibitor would be ruxolitinib today. Although many patients come in anemic, anemia has not been defined in the label for momelotinib. Momelotinib could very well be another option. Fedratinib could be an option as well in those scenarios. I do offer and mention the data for momelotinib to patients who are coming in, especially with hemoglobin less than 10. Okay, so with that being the stage, first answer would be we should offer a JAK inhibitor. What could be the additional combinations that one could consider? Well, right now we don't have additional disease-modifying agents that we would just add as standard of care on a JAK inhibitor. But one could very well consider adding a drug like danazol, for example, or a drug like Procrit or Ananas. So these are ESA therapies for patients with anemia coming in with low EPO level prior to the initiation of a JAK inhibitor to somewhat mitigate anemia, blunt it, while keeping the dose of ruxolitinib as high as possible, at least 10 BID and higher. So that is one. Luspatercept could be added. It's off-label for now. Maybe the independence data will come out positive, be read later this year or so. And that could be an addition for patients who are requiring transfusions on JAK inhibitor therapy. That is my approach to these patients in frontline scenario who are newly diagnosed with myelofibrosis.
Okay, maybe I'll ask Dr. Gangat, your thoughts. How do you approach similar intermediate high myelofibrosis?
Many things.
Oh, is it on? Use that one.
Can you guys hear me?
Yes,
I think
very
this is
good,
working.
thanks.
So I think many things factor in: patient age, patient's medical comorbidities. So the decision to initiate treatment is it requires a lot of thought that goes into it, both in the part of the provider as well as the patient. So the first thing in these patients, especially the younger transplant-eligible patients, is you want to risk stratify them, especially if they're symptomatic and treatment requiring. It is imperative to know, do they belong to the high molecular risk categories? And those are patients, at least in this era, till we get a disease-modifying therapy, you want to refer for at least an early transplant consult. So it doesn't mean that the transplant has to happen next month, but they need to get thinking about that. And meanwhile, if they are symptomatic, we need to discuss treatment. And there is data that use of JAK inhibitors prior to transplant is beneficial in numerous ways. And the first JAK inhibitor that comes to mind is ruxolitinib. That is the most tolerable JAK inhibitor. Despite momelotinib having the anemia benefit, it does come with side effects. And some of the side effects, such as GI side effects, can be quite cumbersome for the patients if you're having to have a number of stools a day, if you need to take an antidiarrheal and an antiemetic, along with a JAK inhibitor, so you're adding 3 medications. So I know we went over some of the selinexor data, like patients were treated with 2 supportive care medicines for them to be able to take it. That is a big deterrent for patients in general. And we have to realize that myelofibrosis is a chronic malignancy, and the survival for these patients is highly variable and heterogeneous. There are patients who can live for decades or longer, especially the younger patients. But it is a disease of the elderly. But if you're type 1 CALR mutated without any other high-risk genetic features, the median survival is over a decade. So we want to make sure that we don't add toxicities and impede their quality of life when you know that it's not immediately taking over their life. Like different from AML, where you're in a very dire situation, where you need to admit them to the hospital, get started with intensive treatment. So I feel like the care of a myelofibrosis patient is a multifaceted approach, and then the cost of drugs does come into. Often patients will require financial assistance, even for ruxolitinib. None of the JAK inhibitors are cheap, as opposed to generic imatinib, which is available. So for CML, at least you have a cheaper option.
Yeah.
So I'll stop.
Thank you very much. Yeah, absolutely. So Dr. Amanam, your transplant obviously still I mean, we say it a lot, but if you look at the transplant rates, they're not very high in the US, right? For myelofibrosis, they should be, I think, higher because all of the guidelines, all the recommendations say for intermediate high, they should be considered. In AML, I would say we are getting very high now into transplant rates, 50, 60, 70% for high risk. So what is your, how do we overcome this? Is this a barrier of not being referred? Is this a barrier of transplanters not being comfortable? Is it a insurance, financial barrier? How do we move these people quickly into transplant who need it?
Right, right. So kind of piggybacking off of what Dr. Gaga mentioned, I think thinking about these patients, you know, if you have a new diagnosis, you should start thinking about if they should be seen by a transplanter. That doesn't mean that they need transplant, but I think that's very important. So I do see that there are instances where that doesn't occur. And I think there's a lot of data that's corroborated earlier transplant is better for long-term outcomes. And I think that with, you know, the influx of newer therapies, you know, now we have multiple JAK inhibitors. I do think that that increases the comfort level for a lot of physicians in the community to take care of these patients. But then what happens, though, is that we end up seeing these patients later, and potentially their transplant window is closed.
Yeah.
And so I do think there's some education that still needs to be done. And when I say some, meaning transplanters, in letting everyone else know that it's still important for us to be able to see these patients earlier.
Right.
We know that there are risks related to transplant that are outside of, you know, our standard risk stratification for myelofibrosis.
Mm-hmm.
And us being able to see these patients earlier would be able to understand if these patients, what the risk status is for transplant. So I would say that's the crux of it. I think we're improving, though. You know, I think another issue is, you know, donor availability.
Right.
You know, the United States is a much more heterogeneous population than, let's say, some of the European centers. And so we do have opportunities now to improve our availability of transplant to more myelofibrosis patients. That data is coming in, so we're still learning. So I think that plays a part as well. And I think, you know, the last part of it is that we have a lot more information, even at ASH, that was presented by our colleagues at Mayo regarding specific patients with specific mutations inside of genetic risk factors, that, you know, there are issues when those patients are transplanted in terms of relapse, survival. And so I do think that, you know, with the help of everyone that's sitting here and everyone that's that kind of is a part of pushing these trials forward, we're trying to figure out how to get deeper responses up front. And I think if we're able to do that, we will improve our outcomes, and that also will encourage people to be able to send their patients for transplant. So.
Yeah, no, I think a lot of work, but you're right. I think in general we're seeing improvement in transplant communication, referrals, and donor pools, and more transplant.
You're watching the HemOnc Pulse Live, brought to you by Blood Cancers Today, a Fermetics property. For more content tailored to your therapeutic area, visit us at www.bloodcancerstoday.com.
So Dr. Prithvi, you're running a lot of the trials, you know, especially the combinations up front. Where do you see the field going in the next 5 years, right? So Pankit nicely highlighted some of the BET inhibitor combo data, you know, some of the other combinations with navitoclax, unfortunately, have not progressed further. We've had HMA-based combinations. There's the EPO and luspatercept kind of things. Which one do you think is going to have a chance here, and how will we use them in the future?
Yeah, so I certainly agree, first of all, with both Pankit and Nasima when they said that, you know, Rux is probably the front line of choice for most patients, although momelotinib is a reasonable alternative if anemia is your main concern, right? Like here, this is a disease where you don't necessarily, I mean, obviously we're not even close to MRD, right? So we treat according to the clinical need of the patient, right? So I think momelotinib can be a good frontline for some patients, but Rux is I think, by far the more established and very well tolerated, survival benefit, all of that. And a more potent JAK inhibitor. Now, as we get into combinations, I think Pankit's point about preemptively treating for anemia is interesting, right? Like we have not quite done that yet, but you start with, say, Rux and luspatercept, something like that. That's interesting, and that certainly could find a place. And yes, Naval, you're the only usable combo today is what you pioneered with AZA.
Before I left MPN and moved to AML, so I'm glad I did something in the
moved on to bigger things. So that is obviously doable today. It's the only thing one can do today. But I think it's not clear for whom, right?
Correct.
I mean,
Correct.
which patients, you obviously higher blasts, absolutely,
Right.
you have to
Right.
consider that. Now, the other combos, right? So we talked about pelabresib, we talked about selinexor, we talked about naftamadlin with its unique trial design. Now, Naseema made a very good point that, in this disease, it has to be tolerable.
I agree.
It cannot be something you're struggling with on a daily basis, and patients won't stay on it. So there I'll make the point that pelabresib, actually, 430 patients, large phase 3, among the largest, really good tolerability. If you look at the two arms, they're the same. I mean, big picture, right? Like, obviously, there's nuances and differences in specific side effects, but that is one combo that is tolerable in a very large phase 3 trial. Selinexor, very exciting in terms of response rates, but we'll have to see about the nausea long term. We'll have to see how that goes. Naftamadlin, in my experience, also has some of those issues, although they are designing it differently. They are designing it so that, as Pankit showed, you start with Rux, you stay on Rux. If you are suboptimal, you add it. Maybe that could be an evolving strategy. So I think these combos certainly, in the near future, we'll learn more, and I think the field is going towards combos. But actually, I want to go back to a discussion you and I and some of our other colleagues had in the office a few days ago, when we were saying that if we get really potent drugs, right, we may not need the combos. That was your remark, actually.
That's correct.
So, we have the Ajax drug, right? So
Yes.
Ajax is a type 2 JAK2 inhibitor, very different type of binding. It overcomes persistence, at least in the lab, in the hands of Andy Dunbar, Ross Levine. Extraordinarily potent drug. So if we get drugs like that, or the mutant CALR, right, the bispecific or antibody, if we can really hit the driver hard, maybe we won't need combos.
Yeah, I was gonna, that's exactly where I was gonna go next. I think, the difference with the JAK inhibitors and the TKIs and CML, even though if you ask like a resident or fellow or, even some faculty, they think these are very similar conceptually, but they're not, right? One is completely eradicating the uni-driver clone of that disease for a curative outcome. The other one is broadly suppressing a pathway, but it is not really eradicating that molecular entity. But now you're right, there are a number of those. Ajax has, Insight has JAK-specific molecular targets, and if they work like that, then yes, I mean, if it could become like CML, that would be great. Now, there are other issues, as of course, cytokines in tumor environment, but that will be kind of a very nice
Cytopenias maybe as well.
Cytopenias. So from that, actually, cytopenias, so like we talked in MDS, right? There are people, the high risk, the blast, high, big spleen, we talked about those. But what about those who come predominantly with cytopenia, those 20-30%? What is our approach to those patients? Are there drugs? Is luspatercept close to getting some data? Are there KER, others like that? Maybe we can start with you again, Pankit, and see how do you manage anemia, thrombocytopenia?
Let me answer on what we could do right now, and perhaps some others can answer what could be done in future. So let's say someone comes in with severe thrombocytopenia, platelets less than 50. There we have now two options. One would be pacritinib, that is approved specifically for patients with platelets less than 50, line-agnostic fashion. And that would be a drug of choice in that scenario. Momelotinib could also be done in that scenario. It has been studied in a few patients with platelets less than 50. Typically, also, let's remember, severely thrombocytopenic patients are also anemic at the same time. Now, what about anemia as a focus? let's say if you have a patient coming in transfusion dependent, requiring multiple transfusions, or a transfusion requiring patient, one every few months or so, or a person with just hemoglobin less than 10. Like I said before, momelotinib could be offered in that scenario. The other option, of course, is using ruxolitinib plus minus using additional supportive options like ESA therapy, luspatercept, danazol. So there we do have the choices to make from, and hopefully additional trials will help answer some of our questions. Meaning, is it important to just bring the hemoglobin up, or does the treatment that you use to bring it up make a difference in the overall outcomes? Why is it that the patients who have anemia improvement have long-term good outcomes, including with survival? So is it an issue of a drug, or is it just the fact that you brought hemoglobin up and that responders do well anyways? So that's that for that. Now, the scenario that comes up quite frequently, and I'm not going to be able to answer and give you one answer to pick from, but I'll give you some options. The scenario that comes up frequently is platelets 50 to 125. Patients come in that range either upfront or at some point down the line. There you really have 4 options. Rux can be done. We have data for Rux in frontline even with the EXPAND study, 10 BID as a starting dose plus minus up titration 12 weeks and beyond. Fedratinib can be done at full dose. We have seen that from Jakarta. Momelotinib can be done. Once again, these patients might very well be anemic. And last but not the least, pacritinib has data from PERSIST-2, for example, where patients, again, frontline or second line, had platelets less than 100. So that is a gray area with multiple options. And as we have spoken in a different setting before, picking the right drug for the right patient, keeping in mind the comorbidities, keeping in mind other issues, including how they may fare with adverse events if and when they were to happen, might be a good idea. Plus, of course, additional data will help clarify this question.
Thank you. And let me ask you, Dr. Gangat, so the rusfertide data, right, very exciting, was New England already phase 3. How are you going to use this data? You think this is a major game changer for PV, will be used upfront, or maybe not as excited? I don't know what the side effect profile is. What are your thoughts on that drug? Yeah.
So I know we're pivoting to PV, but just one last comment on MF.
Yeah, of course. Sure.
So as we were talking about finding drugs like TKIs for CML, the danger with even CALR and JAK2, specific JAK2-directed therapies, that the other clones could get even more prominent. Like we have 80% of patients have other mutations,
right,
and some of them are high-risk mutations. So you may suppress the CALR clone, but you may get like a higher ASXL, which may lead to progression. So I think that's been the struggle in the MF field, and we have not been able to recapitulate the success as seen in AML with the approval of several agents, and even in high-risk MDS, that's a challenge, as was highlighted this afternoon. So now going on to rusfertide. So I think the data is very exciting. It actually lends to a very different mechanism of action, like hepcidin mimetic. And there are several agents even in that area that are still in development. Some of them are going to be dealing with the endogenous hepcidin to increase that, and they actually might end up being more safer in the future, because in this one, you're still kind of, it could lead to side effects. And there was a concern for cancers, which has been addressed in the recent data, but I think it is a very valuable choice for perhaps younger patients. If you're not on cytoreductive therapy and you have high phlebotomy needs, it would be a good space for rusfertide. If you're a patient who's already going to be on cytoreductive therapy, I guess if you have ongoing phlebotomy needs, when it was studied, it was used in combination with cytoreduction too, but then you could argue for the young patient as well, if the ROPEG data is as compelling that you're reducing the JAK2 allele burden and potentially have improved event-free survival and disease modification, would you use ROPEG versus rusfertide? So I think there is a lot of discussion points in the use of rusfertide, but the field has really moved away because phlebotomies are very cumbersome, especially patients develop symptomatic iron deficiency, which is a challenge to manage in clinical practice, and we are kind of going through a vicious cycle, sometimes giving IV iron, sometimes having to set up more phlebotomies or add cytoreductive, but I know we're looking forward to the plenary session at ASCO, where the data will be presented by Dr. Kukendall, and it's a very exciting area for the MPN field. And pivoting to anemia, there is other drugs in development targeting the hepcidin pathway, which is differing from luspatercept, because luspatercept is more directed against ineffective erythropoiesis, and in myelofibrosis, there is more iron-restricted erythropoiesis with the increased hepcidin. So we, in phase 2 study, is another compound, which is an anti-hemojuvelin antibody, which is showing equivalent results to elritercept, which is also in testing for MF and MDS. So the field is very exciting and moving in different combination strategies as well as single-agent strategies and newer pathway approaches.
Great, very nice, thank you. Dr. Morrow, you want to make a...
I was just going to ask a brief question.
Yeah.
CML guy asking
Sure,
an MPN. No. So in a younger PV patient, some of them might need SETA reduction. How do we get away from hydroxyurea? Because hydroxyurea still has effects on the white count, which probably modulate risk, platelets to a lesser degree, the vascular endothelium, whereas resveratride is a much more narrow mechanism of action, and we're worried about that it doesn't do some things, and also that it may, so it's the sin of omission, it may not be doing some of the things hydrea does or interferon does, and also maybe the sin of what it could do for adverse effects. And then there's this comparative data with interferon, which we struggle to try to say it's superior interferon. How do we get away from that with hydroxyurea?
Maybe let's, Dr. Bose, you want to start, give some thoughts on that?
Yeah, sure. No, I would say, Michael, that I would offer a younger patient for sure Besremi or Ropeg. You know, with the event-free survival improvement that's been shown at 6 years, the JAK2 allele burden coming down, I think we are as a field making a move away from hydroxyurea. And Nasima alluded to this as well. You know, rusfertide is great at what it does, but it is not a disease-modifying drug, as you pointed out. It is doing one thing really well. Right. So I think it's more of an adjunct. I view it as more of an adjunct, where, you know, let's say the patient that's on Hydrea or Rux or Ropeg, but still needing phlebotomies, it could very nicely, you know, deal with that issue. Or perhaps in a young patient where you are just thinking otherwise phlebotomy aspirin, you could replace phlebotomy with rusfertide. But we have to remember that we are not impacting the clone with this disease, with this drug, right? So that is where I think Ropeg has an important role to play.
Yeah, and I think Pankit, the point you brought up is very important, right? Is it just the factor of improving hemoglobin that leads to a better perfusion and survival, or is there actually something that is associated with that improvement in hemoglobin that is having a direct disease-modifying effect? This is a big question in MDS as well, right? With lenalidomide, with luspatercept, are they doing something beyond the hemoglobin that is giving us this, or imetelstat, for example? So I think this is something we don't know yet. Let me ask you, Dr. Amanam, you're more on the transplant side, right? So post-transplant, I know there was data in the past about using JAK inhibitors as maintenance. I think Dr. Gupta, others were showing these. What is your procedure today? If you took a high intermediate risk myelofibrosis transplant, successful, now back with you 3 to 4 months later, is there something you monitor? Do you use JAK2? Do you use symptoms? Do you use a JAK inhibitor post-transplant? Do you do it for everybody? Do you do it for nobody? What are your...
Sure. So I think first I would kind of actually go backwards a little bit. Think about pre-transplant. You know, I think we have some data, you know, EBMT data is presented a couple of years ago now, that spleen size is very important going into transplant. So you want to make sure the patient's optimized. I think we've all agreed here that JAK inhibitors are the appropriate therapy. So you want to make sure that a patient is on a JAK inhibitor prior to transplant. Next is, what do you do about that JAK inhibitor going into transplant? I think the practice of our center is that we keep patients on JAK inhibitors. I wouldn't say JAK inhibitor, because currently, I mean, we have data from multiple centers, including our own, that's been published using ruxolitinib for peri-transplant management, which includes graft versus host disease, in addition to what I like to call kind of control of, you know, the symptoms and the issues associated with those symptoms going into transplant. So, you know, median engraftment, typically when we use our, you know, do Flumel, which is our reduced intensity conditioning regimen, Tacrocero for GVHD prophylaxis, you add Jakafi to that. Traditionally, our engraftment times are usually about 20 days or so. Jakafi actually improves that engraftment. So, so your median is about 15 to 17 days. So when you look at data for patients who receive Jakafi, you have improvements in our NRM, you have improvements in acute graft-versus-host disease, chronic graft-versus-host disease, and survival. So I think definitively that's something that should be used. Post-transplant, that's the question. Right. We typically used Jakafi all the way up to day 30. And then after that, if there's no graft versus host disease, it stopped. There have been other studies. Itacitinib is one of them that is not FDA approved, which was used in conjunction with Tacro-Cero all the way up to day 100. And you had also improvements of kind of the same measurements that I just mentioned. In terms of measuring post-transplant, I know there was a presentation at ASH this past year where we looked at chimerisms, which we typically use for kind of assessment of, kind of donors, donor chimerism versus recipient. And nowadays with our molecular, I think everyone uses NGS, looking at those driver mutations, it appears that looking at the driver mutations is just as good or maybe better than looking at chimerisms. Yeah. We traditionally have been doing that for, I would say, the past 5 years. So we do look at the mutations post-transplant. And what do you do? Let's just say that, day 100, the JAK2 reappears. Right. And has a high variant allele frequency. Right. If they're still on immunosuppression, obviously, first thing is that we're going to rapidly taper immunosuppression. Harris Ali, who was actually supposed to be here, but he hurt his knee. Yeah. We published our data about salvaging these patients using an HMA post-transplant, and so that would be our first approach. And typically, for most of those patients, up to 80%, they're able to go back into molecular remission with the HMA. So I'd say that's kind of how I look at this.
Your approach. Yeah, fascinating. Any questions from the audience? Yes, please.
My question is to Dr. Anand. So, two things that was interesting for that detailed response. Going into transplant with a patient who is on a JAK inhibitor and who has splenomegaly, what's your, to what degree does the spleen shrinkage have to occur? What's your threshold? Say the patient is feeling better, but they still have some palpable splenomegaly. The spleen reduced some, but you can still palpate it. Do you have, any sort of established protocols, and what's the level of evidence? And then the second is you said that when you see reemergence of JAK2, one of the strategies you use is using an HMA. Is that HMA monotherapy or HMA in conjunction with a DLI?
Great questions. I think, so the first question regarding spleen size, if we're relying on the EBMT paper, I would say 15 centimeters was kind of the threshold. I think in clinical practice, I would say it's closer to 20 centimeters. With melphalan, my expectation is that we're going to be able to shrink the spleen well enough to where we don't have problems with engraftment, but once the spleen is larger than that, I think the engraftment issues really come into play. What if your spleen is 25 centimeters and you received, a JAK inhibitor, but it's only been for about 8 weeks? My recommendation would be to continue on the JAK inhibitor in order to, with hope that you'll have optimal response within, up to 12 to 24 weeks. So I think that would be, my recommendation. And there are instances where patients have thrombocytopenia, and when we get these referrals, obviously let's just use ruxolitinib, they're on 10 milligrams twice a day. I typically bite the bullet, and I'll treat these patients as a patient that I would see, in our transplant clinic, so we'll see them very frequently. I'll push the dose of ruxolitinib up higher in order to hopefully get a much deeper spleen response. And using the data from the Comfort 1 and Comfort 2 studies, that's where I would argue for increased dose of ruxolitinib. Sorry, I forgot your
DLI.
DLI with or
DLI.
without AZA, together or?
Sure.
Yeah, sequence.
Sure.
Yeah.
Thanks for that question. Internally, we haven't published our data, I would say, but our current practice is we typically give 2 cycles of HMA, and if you still have, donor chimerism hasn't gone back up to 100%, then the plan is at that 3rd cycle to perform DLI. I would say, I don't have all the data to be able to tell you exactly, but I would say majority of those patients, if they're refractory with just HMA, they are able to be salvaged with DLI. I think DLI, obviously in the AML world, dependent which transplanter you talk to is pretty much frowned upon or not recommended. I think in patients who have MPNs, and so the spectrum expands beyond myelofibrosis. I think that includes CMML as well. We see really good responses with HMAs and DLI. And so my recommendation would be to offer DLI to those patients.
Okay, I think it's late now and everybody's tired. So that was a fantastic, actually it was a really nice panel. I really liked it. As you all know, I see some MPN CML, but not as much, and it was really good to see the insights and in-depth discussion. So with that, I'd like to thank all of the panelists very much for this discussion, and I think we're here at the closing remarks. I'm going to invite Dr. Saad Usmani to join me. So let me see if there's any slides, but overall I think it's just to thank everybody very much for coming and for participating, and hopefully next year we can get even more attendees, and there's efforts now to get more fellows. I was discussing with the HemOnc team and maybe some of the community faculty in the future, but this is recorded and will be on the HOP website, which has a lot of traffic is my understanding, so do not worry that all of the time and effort you have spent will be actually viewed. But I also think people really love this. I mean, you get to see, I've been to like so many meetings in the last few months, as is Saad and others, and you see people presenting slide after slide after slide, and it's like the same slide and again and again, but you almost never see this kind of discussion and thinking about how a transplanter is doing things, how the MPN, CML people are actually doing the day-to-day management of PCRs and things like that. So this is, I think, very high value for everybody. So we'd like to thank our sponsors, Bristol Myers Squibb, Johnson & Johnson, Rigel, Menarini, Stemline. I'm going to ask Saad for some comments, please.
Thank you so much. Thank you to all of you for joining. It was a very stimulating discussion. It's actually good for these kind of forums to think about the unknowns. And one of the things I truly enjoyed in the sessions yesterday as well as today is insights on the questions that we don't know anything about, and we learn from each other's experiences. The same is true for the lymphoma sessions. The myeloma session was very inviting. There are more things we disagree on than agree on, but at the heart of it, what we're trying to do is have best outcomes for our patients. So it was really stimulating, and I hope you'd be able to join us in the future rendition of the program. Thank you. And we are going to have a reception closing dinner in about an hour. It's just a couple of blocks, less than 3 minutes walk from here. So look forward to having all of you there. Thank you so much.
Thank you. And there's some pictures here. Thank you very much. So we have some nice action shots there from everybody. Very animated. And I think that is it. Thank you all very much. Thank you.